Hey everyone, so welcome to your first ultrasound lecture as part of the Charlotte curriculum. Today we're going to talk about ultrasound physics. I know, hold on to your seats, get excited. I know you all love physics and it's your favorite topic. So we're going to backtrack a little bit and talk about why we use clinical ultrasound. So in emergency medicine, we're usually trying to make some pretty big decisions regarding patient care really quickly. We want to narrow our differential diagnosis and start treatment, or start appropriate treatment, I should say, as quickly as we can. And we want to use all of our tools to enhance patient care. Clinical or point of care ultrasound is both physician performed and physician interpreted, so it differs in that way from comprehensive ultrasound. So we're using clinical ultrasound to help us answer a very specific clinical question. So first we want to make sure that we're getting a really good history and doing a good physical exam, and then we're building our differential diagnosis and developing our clinical question as you would with any other test you order. For example, does this patient have a pericardial effusion that could be causing their hypotension? We consider it as complementary to the physical exam, but a separate procedure. But it's a separate procedure and not part of the physical exam. There are many aspects to a good quality point of care ultrasound program, but that's a little bit beyond the scope of this talk. In emergency medicine, we often use point of care ultrasound to diagnose and start treatment on acute life-threatening conditions and to help guide procedures. Other reasons that we use ultrasound are that it's actually a pretty safe imaging modality. There's energy transfer, but there's no associated radiation. It can be safely and usually pretty quickly repeated on patients if there is a change in their condition. So, comprehensive ultrasound by radiology is a complete and thorough assessment of a particular region. For example, a comprehensive right upper quadrant ultrasound will look at the kidney, will look at the liver, the vasculature, the gallbladder, and the pancreas. Whereas if we are performing a clinical or point of care ultrasound on the gallbladder, we might be looking for gallstones, gallbladder wall thickening, and size of the common bile duct. Big question, is ultrasound good for everything? I would like to be able to come up here and say yes, but not quite. Ultrasound is great for many different anatomical structures. It does have limitations, especially when it comes to air and bone. Any point of care ultrasound truly relies on the skill of the operator. So what are we going to talk about today? We're going to introduce you to the basics of ultrasound physics, as well as instrument orientation, image acquisition, orientation, and ultrasound anatomy. So let's get started. I'm borrowing this from a friend, but if you all remember the movie The Matrix, you might struggle to understand ultrasound, what you're looking at, and then one day it just clicks and you're in the matrix and then you're seeing ultrasound. So I challenge you to correlate every image that you perform now to the patient's anatomy, and then it should at some point within the next 6 months just start to click. So first, a little bit of ultrasound physics. Physics 101. I knew you all thought you were done with physics. Ultrasound is a sound energy that is based on the propagation of sound waves. Examples of this in nature are the communication of bats and dolphins, as well as sonar. Sound is a longitudinal mechanical wave, so this ultrasound wave does have energy. This wave, so this longitudinal mechanical sound wave, is a kinetic energy that travels through mediums. The sound wave is sent from the ultrasound probe to an object which reflects back the waves, and the probe then acts as a receiver as well. So what is sound? Sound is a mechanical or kinetic energy wave that travels through mediums. Vibrating particles disturb the medium and create this sound wave, much like the vocal cords, the strings of a violin, or the tines of a tuning fork. And that's what happens with the ultrasound probe itself. A longitudinal wave travels from the source, so from left to right, and causes waves or coils to move from left to right. The motion of the particles is parallel and anti-parallel. So we can see here that a longitudinal wave motion is composed of these areas called compressions and rarefactions. Please note that the compressions and the rarefactions, so the compressions are the high pressure area as the particles all get crunched together, and the low pressure areas are where the particles are spread far apart. It's almost like a slinky if you think about how a slinky moves. So sound is this pressure wave that is then transported from point A to point B through particle-to-particle interaction. The ultrasound wave displaces a particle in the medium from its equilibrium position, creating a mechanical wave. This wave travels through the medium to complete one cycle. This is normally measured from trough to trough or from crust to crust, but the pressure wave is measured here by compression. And when we're measuring a pressure wave, we know that the wavelength is a distance from crust to crest or from compression to compression. Your period, or T, is the time that it takes to get from crust to crest, and your frequency is the inverse of the period, and in ultrasound it's measured in hertz. So your frequency is measured in hertz, which is the number of cycles per second of a periodic phenomenon. 1 hertz is 1 cycle per second. We humans normally hear at a frequency of 20 to 20,000 hertz. Diagnostic ultrasound works at a frequency of 2.5 to 12.5 megahertz. The speed of sound wave is different as it travels through different mediums. However, it is constant for a given medium. In the human body, ultrasound wave is going to travel through your liver at about 1,550 meters per second, and it's going to travel through kidney at 1,560 meters per second. Notice that the extremes are going to be your air and your bone. So, getting a little bit deeper into sound physics, the speed of sound, c, is the wavelength times the frequency, and c is a constant. So the frequency is inversely related to the wavelength. Frequency is a property of the ultrasound transducer, and it's set by the frequency at which the piezoelectric crystals vibrate. Through some super advanced calculations, which we are not going into, as the frequency increases, the wavelength decreases. Why is this important? Well, it helps you choose which ultrasound probe that you're going to use. We have high frequency probes and we have low frequency probes. So as you can imagine, the high frequency probes have a much shorter wavelength and the low frequency probes have a longer wavelength. Each ultrasound transducer will emit a packet of these wavelengths, about 3 complete wavelengths, and that's called a spatial pulse length. The spatial pulse length is also a property of the ultrasound transducer. So if you increase the frequency of the probe, the wavelength decreases and you have a smaller spatial pulse length, which gives you better axial resolution. So we remembered that the frequency is inversely proportional to the depth of penetration. Higher frequency ultrasound probes cannot see deeper structures. So a 10 megahertz probe, which is the high frequency probe, is going to image down to about 6 centimeters, whereas your 3.5 megahertz probe, so a lower frequency ultrasound probe, is going to measure to a depth of about 20 centimeters. When we're looking at our probes, we want to use our high frequency probe for our little itty bitty pediatric patients, for anything on the skin, soft tissue, superficial vessels, bone, and ocular. We want to use our lower frequency probe for adults, looking at their abdomen, their aorta, and cardiac views. So when we talk about ultrasound wave production, or the magic that produces the ultrasound image that you see on the screen, we have our ultrasound probe that houses these piezoelectric crystals. A charge or a voltage is applied to these piezoelectric crystals, which can be natural or man-made, and then these crystals start to vibrate at a given frequency. The vibration of the crystals produces a sound wave that then travels through the medium to an object and is then returned back to the ultrasound transducer in the crystals, which act as a speaker and then receiver. The received signal is then translated to an ultrasound image that we see. One thing you want to know about is ultrasound resolution. So this is the ability to differentiate two objects in a plane. You have axial resolution, in which you are looking at differentiating two objects in a longitudinal plane, and then lateral resolution, which is differentiating two objects side by side. Your axial resolution depends on your frequency. So higher frequency leads to better resolution, right? This is because you have a smaller spatial pulse length, which means that the transducer spends more time listening or receiving the signal than it does sending out a signal. Your focal zone, so this is something that we can set on the ultrasound machine, should be the center of your object. So we can control where your focal zone is and place it on the ultrasound machine to line up with what you want to visualize. We refer to the near field as the area that is closer to the transducer, so closer from the focal zone to the transducer, and you usually have more precise imaging in your near field. You have less ultrasound signal divergence. Far field is on the opposite side, so further away from the focal zone, and objects here are more difficult to visualize given the divergence of ultrasound beams. So your focal zone is where your ultrasound beams just focus right in, and this is going to be your best resolution. Time gain compensation controls echo amplification at different depths. So your gain receives and amplifies the images coming in. It modifies and processes incoming echoes, and too much gain can lead to more scatter. Your near field gain are the echoes closest to the transducer, and your far field gain would then be your echoes furthest away from the transducer. Your ultrasound gain affects the grayscale, or how images are viewed. So increasing the gain is increasing the received signal intensity. So we want to make sure that we're able to differentiate different structures with appropriate grayscale. So you definitely do not want to turn your ultrasound gain up too much or down too low. So here we have an example of too much gain. So too many signals are coming back, leading to a really poor, very fuzzy image overall. You can't really make out the structures that well. I think about it like when you turn your speakers up way too much in the car, the sound then becomes really fuzzy and just terrible. So that's the same as ultrasound gain. So too much here is definitely not a good thing. I would show you an undergained image, but it would just be really dark. We then want to make sure that we're adjusting the depth appropriately to visualize the image that we're looking at. So right here we're looking at an image of the heart, and I say that you need less depth here. So the entire image is in the very top of your screen. I want to decrease our depth in this image here. But right here, we decreased our depth a little too much, well, or a lot too much. The depth here is set at 7.5 centimeters, and you can see a scale over to the right of the screen where each dot should be a centimeter. So here, unlike the previous slide, we need to increase our depth. And this one is just right. So make sure that you have the appropriate gain and make sure that you have the appropriate depth. Now we're going to talk about some of the other ultrasound terms that we use. So you might hear us say something about a hyperechoic structure. Now, a hyperechoic structure is going to appear bright white. All of the echoes are reflected back. Some examples of things that we see that are hyperechoic are going to be your bones, your stones, such as gallstones, or anything really with a high acoustic impedance. Medium echoes are your somewhat reflective structures. This is going to be your soft tissue. Your solid organs, such as your kidneys, your liver, or your spleen, all give you that nice medium gray, medium echo. hypoechoic, or anechoic. Anechoic means without echoes, so hypoechoic is also darker or with less echoes. Anechoic is going to be completely black. So these are not reflective structures. The signal just passes straight through, and we generally associate this with our fluid-filled structures. So think about the gallbladder, think about cysts, and think about the bladder as your anechoic or hypoechoic structures. We also rely on different acoustic windows to image through with ultrasound. So we can use a solid, soft tissue such as your liver or your spleen, or a fluid-filled structure such as your bladder to act as a window to other areas. Now let's talk about our ultrasound transducers. The first one is our linear probe. This is your high-frequency transducer, and it's great for superficial resolution. Remember back to the frequency wavelength discussion we had earlier when you were hoping that you were completely done with physics? So that's why we choose our linear probe here. Our curvilinear probe is one of my favorites. We consider it a jack-of-all-trades probe. It's a great choice for many critical care applications, namely abdominal and thoracic imaging. So this is a lower frequency probe at 2.5 to 5 megahertz. So better imaging of deeper structures, so you lose some of that spatial and axial resolution. And then finally, you have the phased array probe. So this is a lower frequency probe, 2 to 4 megahertz, and it's a sector probe that gives a pie-shaped image. The footprint of it is a little square that fits easily between ribs, which is why we use it for our cardiac applications. It can also be used for abdominal applications. And what are some of the modes then that we use with ultrasound? You'll hear us talk about this a lot too. So B mode is brightness mode. This is a 2D ultrasound that you commonly use when ultrasound scanning. So this is the ultrasound image that you are used to seeing that is in every textbook when you look at an ultrasound. That is B mode. We then go to M mode, which is your motion mode. So this is a series of B mode images displayed over time on a moving basis. You can capture motion of a moving object, like the heart as it's beating, to determine the heart rate or the fetal heart rate. So what we will do is we'll drop an M mode line through a particular plane of our B mode image, and then it will record that motion in that particular plane over time. One other thing that we use is Doppler. So think about the ambulance siren as it comes to you and then away from you as you sit in traffic. Your blue shift is when the waves are more compressed, so blue light is emitted. Doppler effect is your change in frequency or wave as it moves relative to its source. It's often described in terms of color, so Doppler red shift is waves moving away from the source, and blue shift is waves moving towards the source, so they are more compressed. We use Doppler to detect blood flow, and this depends on the frequency, the velocity, and the angle between the sound beam and the blood flow. So your angle of intonation is the angle at which the beam is directed and should be 45 to 60 degrees. If it's a perpendicular angle, then you're going to have a weak Doppler signal. And taking a step away from your red shift and your blue shift, with Doppler and ultrasound, red means towards the transducer generally, and blue is away from the transducer. Every ultrasound will have a scale to the side, and you'll have red on top and blue on the bottom to indicate that red is towards the transducer or blue is away from the transducer. However, this is a property of the ultrasound machine, and that can be changed, so always look at your scale. It doesn't mean that red is artery and blue is vein, not at all. It's the direction towards or away from the transducer. We also use pulse wave Doppler. So pulse wave Doppler uses a sampling gate, and that sampling gate allows you to measure velocities within a certain location. You can change the position of the sampling gate and then change the direction and magnitude of the flow. So in this particular image, we have our sampling gate for pulse wave Doppler set at the aortic outflow tract in an apical 5 view, and we are looking at the flow of the blood as it goes through the aorta on its way from the aortic valve, the left ventricle, through the aortic valve out into the ascending aorta. We can also use this to measure the velocity of tissues as they move with ultrasound. We do want to talk about some ultrasound artifacts. So the ultrasound machine assumes that when an ultrasound pulse or wave goes out and hits tissue, it's often reflected right back to the machine. When this does not occur, then you get artifacts, and you have to know what the artifacts are to know how to interpret them. One of the first things that we see is signal attenuation. So ultrasound signals will grow weak as they travel over a distance. Some of these signals are reflected back, some bounce off of other materials such as gas and scatter, and then some of the energy is absorbed, and then some is just attenuated or diminished as it passes through a medium. One of the other ultrasound artifacts that we see is shadowing. So shadowing is a signal void, so an empty black space behind a highly reflective object such as bone or stone. Or this can also occur at areas of acoustic mismatch such as soft tissue and gas. So if we can see right here, we're looking at the ribs, and we'll see rib bone and then see shadowing just beneath that. The next ultrasound artifact that we come to is something called posterior acoustic enhancement. So we're looking at the eyeball here. We also see this when looking at the gallbladder, when looking at the bladder. So the ultrasound wave accelerates through the area of fluid faster than it does the surrounding tissue. So there is essentially just zooming through the area of fluid, and they hit the tissue behind them with more intensity as they have not been attenuated. So this means that the tissue on the back side will look a lot brighter than surrounding tissue. Edge artifact is now we're starting to see what appears to be shadowing at the edges of a round or a cystic structure, and we're not actually seeing shadowing, that's edge artifact. So it's the refraction of the sound beam from a curved reflector that causes returning echoes to be weakened and shadows appear distally. Then we have mirror artifact, and this is something so interesting because if you look at this heart right here, it almost looks like you can see another heart beating just on the other side of the pericardium right here. But this patient doesn't have two hearts. This is just mirror artifact. So mirror artifact occurs when an ultrasound beam is not reflected directly back to the transducer after hitting a reflective surface, but rather it takes an indirect return journey. With mirror image, the ultrasound beam hits at an angled, highly reflective surface, such as soft tissue or gas interface, at the pericardium, or even the diaphragm. It's reflected off into surrounding soft tissue, and when it encounters a second reflective object, it then begins to its return journey back to the transducer along the same path. The ultrasound machine assumes that the beam has been taken that the beam has taken a direct path, and that the mirror image is created then deep to the mirror surface. Right here in the schematic to the left, the blue arrows are what the ultrasound machine assumes that the ultrasound beam is doing, but that's not in fact the case because you have a highly reflective surface at an angle going from top left to bottom right. Then one of the final artifacts that we see with ultrasound is something called reverberation. This is multiple reflections at an interface. This wave encounters two parallel reflective surfaces perpendicular to the path, then the ultrasound gets trapped and bounces back and forth before returning to the transducer, causing this reverberation artifact that we're seeing. And this reverberation artifact is caused by a needle being placed into a vein. Finally, we have to know our ultrasound orientation. So every ultrasound probe is going to have a probe marker on one side of it. So look for that probe marker, learn where it is on every ultrasound probe that you pick up. This probe marker then corresponds to a little dot that is located normally in the top left of the screen. Oftentimes we'll see on different ultrasounds that the dot might reflect the first letter of the ultrasound machine itself, such as our Mindray might have an M in the little dot, Zonari might have a Z in the little dot, and the little dot acts as your compass. So this is your guide for orientation with ultrasound. When we think about transverse orientation, so we all know our transverse or sagittal planes for orientation. So we're going to line the probe marker up, which is going to correspond with the marker on the machine. Remember though that the marker on the machine can be changed manually or might change if you're doing a cardiac ultrasound. More on that later with the next lecture. So your ultrasound marker here should point towards the patient's right. So then when we look at the image, that probe marker should line up with the dot, we see it here in red, on the image. So then I know looking at the patient's image on the ultrasound machine, the portion on the left side of the screen corresponds to the patient's right. So then the right side of the screen, that portion of the image corresponds with the patient's left. I also know that whatever is at top of the screen is whatever is closest to the transducer, and then what's on the bottom of the screen is what's furthest away from the transducer. So if we're looking at this image, we know that this is patient's right on the left side of the screen, patient's left on the right side of the screen. At the top of the screen, where you have the transducer, that's going to be the patient's anterior abdomen. The far side of the screen is going to be the patient's backside, and then we can deduce that the patient's head is on the far side of the screen, kind of behind you, and the patient's feet would be coming out to us if we were trying to make this a 3D image in our head. For our sagittal orientation, we then rotate the ultrasound probe to the patient's head. So now we have the probe marker pointing to the patient's head. The indicator on the screen has not changed position, but our probe marker has. So now we know that the probe marker is pointing to the patient's head, so the patient's head is on the left side of the screen, meaning that the patient's feet are going to be at the right side of the screen. We then know that the patient's right hip is going to be coming out of the screen towards us, and the patient's left hip is back behind the screen. Our final view is a coronal view, and we'll use this oftentimes when we're imaging the patient's flanks. So we have our Morrison's pouch or a fast view here, which you'll learn about a little bit later, and the probe marker towards the patient's head. So now we know at the top of the screen is the patient's right, far side of the screen is the patient's left, patient's head is to the left of the screen, and patient's feet are at the right of the screen. Take a moment and try and see where you'll have the patient's anterior side and then where you'll have the patient's posterior side. So remember your coronal or your frontal plane, your transverse or axial plane, and then your sagittal or longitudinal plane. And make this line up with each patient that you're performing an ultrasound on. If you have any questions, please do not hesitate to email me, and I look forward to talking to you in our next lecture.